Dental implants, an overview. Dental implants, also known as oral or osseous implants, have been used to replace missing teeth for more than half a century. They are considered to be an important contribution to dentistry as they have revolutionized the way by which missing teeth are replaced with a high success rate. First, let's take a look at the hard tissue implant interface. Osseointegration is the key biologic and biophysical process that has made dental implant therapy predictably effective for replacing missing teeth. Histologically defined, osseointegration is the direct sutural and functional connection between organized living bone and the surface of a load-bearing implant without intervening soft tissue between the implant and the bone. The discovery of this process occurred by accident by Swedish bone researchers. So here you can see in this image on the left side, the green dotted line represents the surface of a load-bearing implant and the blue dotted line represents the organized living bone. In the image on the right side, you can see implant has been integrated into the alveolar bone and the spaces between the implant surface and the living bone has been filled up by alveolar tissue. So this tight bond of metal implant to bone anchors implants in jaw bones to support prosthetic teeth. The primary goal in implant placement is to achieve and maintain an intimate bone-implant connection. This concept is known as dental osseointegration, defined clinically as the asymptomatic rigid fixation of an alloplastic material, that is the implant, in bone with the ability to withstand occlusal forces. So here you can see this is on the right side is a labeled image of an implant in the jaws. The components of this restored implant are the implant crown, the abutment, and the implant fixture, which is integrated into the bone, alveolar bone. And on the left side, that is a dental implant. Its parts are the crest module, which is present at the level of the crestal bone, the body and apex, which are integrated within the alveolar bone. So as we mentioned that the discovery of this process of osseointegration occurred by accident by Swedish bone researchers on their experiment on animal bone. So there were certain factors that these Swedish researchers found as key to successful implant osseointegration, which are use of biologically compatible materials such as pure titanium, implant surface free of contamination and implantation site free of infectious and other diseases, use of an atraumatic insertion technique that minimizes heat damage to bone adjacent to the implant surface, such as use of sharp drill bits, gradual increase in width of implant site using graduated drills, cooling of drill bit during drilling, and ultra low speed, high torque drill for implant site tapping and implant insertion. The goal is to not allow the temperature of the bone being cut to increase to greater than 47 degrees centigrade or 117 degrees Fahrenheit during implant site preparation. Close approximation of the implant surface to the surrounding bone, which include precision in site development and implant insertion and tapping of dense cortical bone. Delayed implant loading, that is prosthesis placement, gives time for the biological process of osseointegration to occur. Available bone is particularly important in implant dentistry and describes the external architecture or volume of the edentulous area considered for implants. An appreciation of bone density and its relation to oral implantology has existed for more than 25 years. In 1985, Lecombe and Jarb listed 4 bone qualities found in the anterior regions of the jawbone, which were quality 1 bone, which was composed of homogeneous compact bone. Quality 2 had a thick layer of compact bone surrounding a core of dense trabecular bone. Quality 3 had a thin layer of cortical bone surrounding dense trabecular bone of favorable strength. and quality 4 had a thin layer of cortical bone surrounding a core of low-density trabecular bone. Irrespective of the different bone qualities, all bone was treated with the same implant design and standard surgical and prosthetic protocol. Following this protocol, Shintman and others observed a 10% difference in implant survival between quality 2 and quality 3 bone and 23% lower survival in the poorest bone density. Then finally in 1988, Misch proposed 4 bone density groups independent of the regions of the jaws based on macroscopic cortical and trabecular bone characteristics. It is described as D1, D2, D3 and D4 located in the edentulous areas of the maxilla and mandible. D1 bone is primarily dense cortical bone and its typical anatomical location is in the anterior mandible. D2 bone has dense to porous cortical bone on the crest and within the bone has coarse trabecular bone. D2 bone is found in the anterior mandible, posterior mandible and the anterior maxilla. D3 bone types have a thinner porous cortical crest and fine trabecular bone in the region next to the implant. D3 bone is found in the anterior maxilla and posterior maxilla and posterior mandible. And D4 bone has almost no crestal cortical bone. The fine trabecular bone composes almost all of the total volume of bone next to the implant. This is seen in the posterior maxilla. There is also a very soft bone with incomplete mineralization and large intertrabecular spaces which may be addressed as D5 bone. This bone type is most often immature bone in a developing sinus graft. The bone density may be determined by tactile sense during surgery, the general location or radiographic evaluation. Misch also proposed a tactile analog of the corresponding bone densities. Such as, here you can see this is an image of D1 bone, that is a dense cortical bone seen in the anterior mandibular region. On tactile perception, it feels like oak or maple wood. Then D2 bone, this is a cross-section of a D2 mandible in the region of the mental foramen. A thick cortical plate exists on the crest and a coarse trabecular bone pattern exists within. Its tactical analog is a white pine wood. Then a posterior maxilla demonstrating D3 bone with a thin porous cortical plate on the crest with fine trabecular bone underneath. Its tactical analog is balsa wood. And in a D4 posterior maxilla, the posterior crestal region has little to no cortical bone on the crest and is composed primarily of fine trabecular bone. Its tactile analog is a styrofoam, so it will feel like a styrofoam. Now, bone density may be more precisely determined by tomographic radiographs, especially computerized tomograms. Computed tomography produces axial images of the patient's anatomy perpendicular to the long axis of the body. Each CT axial image has 260,000 pixels and each pixel has a CT number which is measured in Hounsfield unit related to the density of the tissues within the pixel. In general, the higher the CT number, the denser the tissue. So based on the CT determination of bone density, Misch proposed relationship of bone density and its CT number in Hounsfield unit. So on the right side, you can see this is a CT image of the maxilla and the mandible. D1 corresponds to more than 1250 Hounsfield units, which is seen typically in the anterior mandible. D2 bone density corresponds to 850 to 1250 Hounsfield units, typically seen in the anterior mandible, posterior mandible, and anterior maxilla. D3 bone corresponding to 350 to 850 Hounsfield units, seen in the anterior maxilla, and posterior mandible. And D4 bone density corresponding to 150 to 350 Hounsfield units, seen in the posterior maxilla. And also there is D5 corresponding to less than 150 Hounsfield units, which we already mentioned is seen in immature bone in a developing sinus graft. Now, let's look at the surgical technique of implants. In brief, we shall just focus on the steps in a sequential manner. So first step is the implant site exposure, wherein a flap is reflected. The exposure of the implant site can be accomplished by several methods, which include flapless surgery or tissue elevation, and can include circular, mid-crestal, and vertical releasing incisions. So in the image you can see using a retractor, the flap has been pulled down to expose the implant site. Following this, next step is osteotomy, wherein the bone is prepared to receive the implant. The area is copiously irrigated. The next step is inserting the dental implant. The implant is opened and placed on the appropriate driver, which has been inserted into the handpiece. And if entirely manual implant insertion is planned, the implant is mounted on the hand torque wrench. Now, following this, a healing abutment is placed, that is known as a permucosal extension, which are dome-shaped intra-implant screws that provide permucosal access to the implant platform. Now, in the image at the top, that is the one-stage procedure, instead of a permucosal extension, following osteotomy, the coronal part of the implant is kept above the bone crest, which protrudes through the soft tissue exposed to the oral environment during the healing stage. Now, after the healing period, stage 2 surgery is performed, wherein the healing abutment is removed. So this is a clinical view after removal of the healing abutment. You can see the tissue has been shaped by the contour of the healing abutment. And lastly, there is prosthetic restoration of the implant. Here, zirconia crowns have been used to restore the molars. So now let's look at the surgical implant placement method. So we already discussed that there are two methods, the one-stage non-submerged method and the two-stage submerged method. The one-stage method, in this technique, the bone is prepared to receive the implant. The implant is fitted into the prepared bone, that is the osteotomized bone. However, the coronal part of the implant is kept above the bone crest, protruding through the soft tissue and is exposed to the oral environment during the healing stage. The restoration can be attached immediately after the implant placement surgery or may also be delayed. The advantages of the one-stage method include the avoidance of a second surgical procedure, the lack of a micro gap between the implant and the abutment at the alveolar bone crest level, resulting in a less crestal bone resorption. The prosthetic procedure is simplified and less chair time per patient is required, and a non-loaded, immediate or delayed loaded protocol can be implemented. One of the drawbacks that may be associated with this surgical protocol is that the implant is exposed to the oral environment, which may lead to contamination of the surgical site. Furthermore, the implant may be exposed to undue trauma, which can negatively affect the healing. Nevertheless, the method can be clinically successful. In contrast, the two-stage method, which is also known as the submerged technique, in this method, two surgical procedures are carried out. The first surgery involves installing the implant into the bone, and a cover screw, also known as a sealing screw, is attached to the implant platform. The raised flap is then repositioned and sutured to conceal the cover screw and the implant. After a few months, the second stage surgery is carried out, in which the implant site is reopened. The cover screw is accessed and then replaced with a healing abutment, which is also known as a sulcus former or transmucosal abutment. Afterwards, the healing abutment is replaced with a provisional or final restoration. So this surgical protocol is suitable for use when the quality of bone is not optimum and when bone graft materials are used in conjunction with the implants. The advantages of second stage surgery are, so it can be used in situations that require simultaneous bone augmentation procedures at the time of implant placement, because membranes can be covered by primary flap closure, which will minimize postoperative exposure. And also mucogingival tissues can be augmented if desired at the second stage surgery in a two-stage protocol. It also prevents movement of the implant by the patient who may inadvertently bite on the healing abutment during the healing period, that is in the one-stage protocol. In general, dental implants may be classified as a one or two-piece implant. The one-piece implant is the one where the implant and the abutment are formed as a single solid unit. In this case, there is no screw joint between the implant and the abutment. The one-piece implants may be used when narrow implants are indicated, such as in the replacement of the maxillary lateral incisors. These types of implants are installed only with the one-stage implant placement method. The two-piece implant type consists of an implant to which an abutment or a restoration or attachment is connected, usually with a screw. It is more commonly used than the one-piece implant type. With this implant type, both the one and the two-stage implant surgery protocol can be implemented. We shall discuss about the individual components in subsequent presentation, as this is just a brief overview of what implants are. But there's a lot more to it, and implant dentistry is quite a vast topic, and we will discuss it in parts. So this was just the beginning, just a brief overview, and we shall discuss more in upcoming videos. I hope you have liked this presentation. Please do like, share, comment, and subscribe to the channel. Thank you.